Everyone, welcome to Wednesday morning rounds for the Division of Cardiology. A couple housekeeping things. Next week, we have one of our C3s presenting, Dr. Laverdure, who will be speaking on athlete's heart. So please register and or join for that. It's my pleasure today to welcome our guest from Toronto, Dr. Beth Abramson. She's here doing a week of PET scanning with us, and she kindly offered to speak to us today. So her interest is in knowledge translation to educate physicians on preventative cardiology and women's health issues. She's the co-chair of the American College of Cardiology Hypertension Working Group and the American Society of Preventative Cardiology Women's Working Group. She was invited to become a member of the ACC's Prevention Council in 2021. She's a founding member of the inaugural chair of the Canadian Women's Heart Health Alliance Education Working Group, which has created electronic online courses and toolkits for women in heart disease. She enjoys educating the public on heart health and is a national spokesperson for the Heart and Stroke Foundation. And her book, Heart Health for Canadians, published in 2013, aims to help people prevent and understand heart disease. She was awarded the Harold Segal Award of Merit in recognition of her many contributions to preventing heart disease among Canadians. So she currently is the Director of Fellowship in Preventative Cardiology at the University of Toronto, and she's going to speak to us today on cardiovascular health in menopausal women. So thank you so much, and we appreciate your talk today.
Thank you. It is a pleasure to be here. Even though when I went downstairs, I thought I was going to the cath lab, I was reading nuclear scans and it wasn't any longer in the call room. So I actually want to go over some important issues for us today. And I want us to make sure we understand as cardiovascular specialists, the issues facing our female patients at midlife. As I get older and as we get older, some of the staff will relate and some of the house staff and trainees may relate. As you get older, it's really important to have the knowledge, but to have the compassion and understanding of where you are in your life is so helpful in making sure we're the best healthcare providers we can be. And so we need to understand the assessment and management of CV risk in the postmenopausal women, review the role of menopausal hormone therapy and CV risk in women, and we'll go over CV risk associated with menopausal hormone therapy, two different things. These are my disclosures. I do not have any major disclosures because I've been involved in guideline writing to mitigate any risk. This is my real additional disclosure. Ottawa Heart Institute has a special place in my heart. As chief resident several decades ago, my project at the Ottawa Heart Institute was PET evaluation of cardiac disease in non-males, or PCAN. Supervisor Rob Beanlands, first international presentation. Dr. Don Beanlands, may he rest in peace, was a master clinician. He'd go fishing and bring residents home salmon and challenge us and agree with me when I now talk to my fellows that I don't believe the echo. Sorry, Ian, I don't believe the echo sometimes because our stethoscope and our ears are still very important. Then I moved on back to Toronto, and during my fellowship at Toronto General Hospital, I don't know if Dr. Peter Liu remembers this, I purchased 200 pounds of soy powder paid for by Dr. Peter Liu for a project on vascular reactivity and phytoestrogens. Unfortunately, it never received REB approval, and I don't know whatever happened to the soy. Peter said, there's a box of soy out there. What are we doing with it? Anyway, those are my additional disclosures for today. My career is that of a guideline writer, and in trying to take care of the whole patient, I was honored to be part of a guideline started by the Society of Obstetricians and Gynecologists, but there is a whole chapter on menopause and cardiovascular disease. And I encourage you to go over, I'm going to go over the salient points here, but if you want more details, it's in the guideline. So I'm going to talk about Mrs. MP because we have to be case-based, I believe. This is a 57-year-old woman referred by their family doctor to you for a cardiovascular risk assessment and palpitations, and someone noted 9 seconds of asymptomatic SVT on the Holter. So you are seeing her in general cardiology clinic. She has hypertension, dyslipidemia, some GERD. She has had a provoked DVT post-op of a total knee arthroscopy, and she has 2 kids. She feels well. She's doing well. You asked. She had normal pregnancies. She did have hypertension or diabetes during pregnancy. We need to ask 25 years ago. And she actually has gone through midlife or menopause. It's okay. I'm giving you permission, and I'm giving the male and female cardiovascular experts in the room permission to ask the questions. When did you go through midlife, if you're uncomfortable with that? When was your last menstrual period? Because someone who goes through premature menopause is actually at much higher cardiovascular risk. And she's having these terrible vasomotor symptoms. Since you open the door and ask, she's like, I'm sweating, I don't sleep. And her family doctor started her on menopausal hormone therapy. So so her symptoms have resolved. She's been seen by gynae with some things that we as cardiologists don't talk about often, but she's feeling better, and she's on some medications that you see here, including conjugated estrogen. If you look at her full list of medications, in addition to an antihypertensive and statin. So that's the background, and we're going to have to figure out why we need to deal with this. Well, we want to understand the issues facing our female patients, and let's go over the assessment and management of CV risks. Let's start off by looking at where we are with women in cardiovascular disease. And I'm sitting here at the Heart Institute, which is an international champion of women's health, with the that started the Women's Heart Health Alliance, and the secretariat being here with friends and colleagues. And we know that cardiovascular disease is a leading cause of death in women worldwide. And women continue to be understudied, underrecognized, underdiagnosed, and undertreated globally due to misconceptions, lack of awareness amongst patients as well as providers. But 1 in 3 deaths in women is caused by cardiovascular disease. And I encourage you to read the paper in The Lancet, if you haven't. Very inspiring in the last few years. So what's a sandwich generation? I didn't know until I became one a few years ago. And it's important for you to know what your patients are going through. Sandwich generation is a term for middle-aged adults who juggle taking care of elderly patients with their own children. And that causes a lot of challenges for our patients in terms of adherence, risk factor management, and wellness. This is a fact. So if you're a bean counter in the room, the average age of menopause is 51. By 2025, it is estimated there'll be 1.1 billion postmenopausal women worldwide. Okay. And cardiovascular disease increases and risk to increase after menopause. So we need to make sure we're addressing these issues. So it's actually interesting that cardiovascular mortality decline, we've been doing well with preventive measures in cardiology. The decline is tapering off in younger women. And I just take a study that looks at a cohort of the ERIC community following young women in the last few decades. And what we're seeing here, and I don't know if you can appreciate that here, is the incidence of AMI hospitalization, okay, in the population aged 35 to 54. Most of us in this room would agree that's a young cohort. You can see the curve for men is coming down, but we're not seeing that same reduction in women. In fact, there's a slight increase. And if you look at hospitalizations in this cohort for young patients with acute myocardial infarction, ages 35 to 54, we're actually seeing a slight increase. And if you see these curves for women, I'm using my pointer, which doesn't show up on your slide, so that's fine. You can see the red curves pointing up and the bottom square. What we actually have is a decline or tapering off in that decline and reduction. And the question is, why is that? Well, I'm going to say it may have something to do with looking at someone's waist. Start off by that as a little clue. First of all, we can talk about menopause in a minute, and we look at visceral adiposity. And if I'm translating that to our patients, that's a more dangerous inner fat. As you know, as women go through midlife, we go from a gynoid fat distribution, a pear-shaped, to an android, apple-shaped fat distribution. We call that in our patients the Canadian tire. And in fact, that is a metabolically active fat. I mean, I could spend a whole rounds on this, but there's a reason, there's a physiologic reason, many physiologic reasons why women are at increased risk. But why are we seeing younger women? So first of all, visceral adiposity is associated with a lot of metabolic derangements that put us at risk for cardiovascular disease, including endothelial dysfunction, glucose intolerance, clotting issues. And so that's that visceral adiposity and central abdominal obesity. So I always joke you can be a pear, but you can't be a big pear. That does put you at risk. But there's another form of increased weight across the belly that seems to be putting women at increased risk for heart attack and stroke. And if I can give you one or two take-home messages during the course of this session is remember when you're taking a history for sex-specific risk factors. When we went to medical school, there are the 5 traditional risk factors for cardiovascular disease, but we need to ask about age of midlife or menopause in our patients. And it's important in a 70-year-old too, because if the 70-year-old went through menopause 10 years earlier premature at 40, was not replaced, on the inside, she's 10 years older. She's an 80-year-old. And your risk calculation as a cardiovascular specialist is based, age drives cardiovascular risk. So sex-specific risk factors. The other sex-specific risk factor has to do with pregnancy, actually. And in fact, Joel Ray at my institution 2 decades ago at St. Michael's Hospital did the CHAMP study and looked at, and I don't know if I have a pointer here, but I want you to see the hazard ratio, okay, for looking at increased cardiovascular risk. And it increases by 2-fold on average, but the more the issues are during pregnancy, thank you, we're going to get a pointer. Okay, so gestational hypertension increases your cardiovascular risk over your lifetime 2-fold, thank you. Preeclampsia, and we can take a history on that, over 2-fold. And if you look at this, look at poor fetal growth, and we look at intrauterine fetal death, these women are developing cardiovascular disease before menopause. So thank you. So we can see this is a tremendous risk factor. And this data is 2 decades ago, published in the Lancet. So what have we done about it? Well, some things, not as much as we'd like to. And in fact, trying to raise awareness. One of my fellows, so I'm talking about how I was Peter Liu's fellow, and I was Rob Beanland's resident, actually, and did a project during my fellowship. But I have fellows now in preventive cardiology, and you have to have your internal medicine or cardiology training to come and join me. That's just a little plug here. But my fellow, Dr. Kajeni Srivadaraja, who actually now runs education for internal medicine trainees at McMaster, and I published a review in CMAJ in 2019 looking at non-traditional sex-specific risk factors. And what you can see is there may be something that is related to pregnancy, or it brings out someone who's predisposed. It's hard to know because you have endothelial dysfunction, you have short-term metabolic derangement, and then what you end up is with long-term cardiovascular risk. And why that is a subject of a lot of research, but it is a fact. And it is a reality, and we need to ask our women, did they have high blood pressure or diabetes during pregnancy? Because I treat those women differently. They're coming in for asymptomatic SVT, and you know you're not going to treat that, but you need to treat their risk so they don't end up in the emergency room in 10 or 15 years at the Heart Institute with a non-STEMI. So we do see preeclampsia and hypertension, and unfortunately we see in the United States, we don't look for this in Canada. There are disparities in care, and we need to make sure we're there and we look at the face of heart disease, which is changing. It is no longer a disease of older, white, gray-haired men. Those are important population that we care for. But we need to remember in our minds, because we're trained to make decisions in medical school and training about, you know, a child who's got a tummy ache is more likely not to have, heaven forbid, something serious in their gastrointestinal tract, but they're upset about something and doesn't want to go to school. And anemia in the elderly is colon cancer till proven otherwise. We need to retrain our brains to think about what a risk is for a patient developing cardiovascular disease. And that woman who had hypertension or diabetes during pregnancy is actually, and preeclampsia for sure, very high risk. So what about reproductive technologies? Yes, times have changed. And my son, who's only 12, through reproductive technologies, is taller than me. I was told that if he wasn't, he'd be a very short kid. So that's good. There's actually a lot of data out there, and it's conflicting because there's limited and conflicting data looking at women who are going for infertility and going for infertility treatments. And, you know, we look at some studies. There was a Framingham study, self-reported, suggesting increased risk factors. Observational data suggested they're not. We're never going to get a randomized controlled trial in this. But, you know, the question is whether it is the infertility that puts that woman at future cardiovascular risk, or the treatments she undergoes for that. But it is something to think about and consider as we're seeing our patients and assessing risk. Okay, so if I'm going to talk about other considerations, we talk about risk calculation in women. So we need to think about sex-specific risk factors and remember to take an OB history and add it to the risk calculation and start with the Framingham risk score. I start off by telling a patient in front of me, just as we have here in Ottawa to some degree, a multicultural environment. Certainly we have more so in Toronto. I said this calculation, we go over Framingham, is based on a group of white people from Framingham, Massachusetts. Probably applies to you. It may not apply to you. It's a starting point. And then we start with the treatment plan. So if I were calculating a Framingham risk, if we talk about, that's POI stands for premature ovarian failure. Shift the age by years in menopause when you're doing a calculation because those women are older on the inside. Very important for us to be aware of. And certainly it's came into our Canadian guidelines, and these are cholesterol guidelines, as many of us in the trainees will know. But in fact, if you look at who is going to be at risk, I suspect we're going to calculate that woman who's had early risk, that is a non-traditional risk factor, hypertension or diabetes, or pregnancy. If you multiply their risk, risk drives age drives risk to much of what we do in cardiovascular medicine, but these women are at increased cardiovascular risk and are probably moderate on Framingham. So then the question is what we do about it. So if we take people who are at moderate risk in Framingham, which are, moderate risk on a Framingham risk score, these individuals got into the HOPE-3 trial. And for those of you who haven't read that in the last few years, it's a lot of people we know, not just our patients. The HOPE-3 trial took men over 55, or women over 60 with 2, or over 65 with 1 non-traditional risk factor. And most people got into the trial with central abdominal obesity. And it looked at antihypertensive treatments, and it also looked at low-dose statin, rosuvastatin 10 versus placebo in these people who would not otherwise warrant therapy. They're now in our guidelines. And over 7 years of the trial, so it took 7 years, compared to placebo, the individuals on rosuvastatin 10, just being, hate to say it, 55-year-old man with a little bit of a Canadian tire, because most of the people in the trial had less heart attack, stroke, bypass, acute coronary syndromes, and death. And so I actually treat most of my patients who are at moderate risk with statin-based therapy. Having said that, we work on lifestyle as we go through it as well. And the trial actually attempted lifestyle. So it's not that lifestyle is a failure. It's that in addition to attempts at lifestyle, we have some good evidence from a population perspective. We also look at the American Heart Association Simple 8 recommendation. Can I make sure that everyone did their Simple 8 in the last week? This is something we don't deal with when we're putting ICDs in patients and they're going to the one thing I also notice is sitting here in the Heart Institute and coming back here for the first time in a while, that the tunnel where we had all these tunnel stories of people arresting, there's now an outdoor tunnel. But anyway, so how many people have had their Simple 8? Okay, so most of us avoid smoking, know your blood pressure, normal blood sugar, treatment of hyperlipidemia, try and avoid obesity. And, coming out of the pandemic, I also ask patients because, they've had this pandemic weight or they haven't. So it's okay to have that conversation with people and not make them feel bad, but work on it. And, low saturated diet. Now, the Simple 7 were regular activity and exercise, but they added another one, is getting healthy sleep. How many people in this room, certainly not if you're up all night on call for cardiology, have you had it? But it is really important and it's underestimated. And there's a lot of physiologic reasons why sleep is important. So I used to say, do as I say, not as I do, but I try and sleep. I actually went to bed early last night so that I could, also because I didn't have my family around me to drive me crazy. I went to bed early last night so that I was up and healthy for you guys. Okay. So let's remind ourselves, because I still get this question in the community from primary care providers and specialists. HRT, or hormonal replacement therapy, which is now called MHT, menopausal hormone therapy, it's not a replacement, so to speak, is not for the prevention of cardiovascular disease. And we do not initiate, and this is from guidelines I wrote 10 years, we wrote 10 years ago, and we've had an update in 2021, and this has not changed, right? We should abstain, it's not for we should not initiate or continue menopausal hormone therapy for the prevention of cardiovascular disease. And we still have educated women coming to us and saying, well, I thought it prevent heart attack and stroke. That's not the case. When we should abstain from prescribing this, I'm going to show you some data in women at high risk for venous thromboembolic disease, and initiate other evidence-based therapies and interventions to reduce the risk. In women with or without vascular disease. Okay, so we got this into the guidelines. We need to have preventive therapies for women that have nothing to do with menopausal hormone therapy. And we look at risk factors for stroke, should all be addressed in postmenopausal women. Okay, so this is what I actually spend a lot of my fellowship training my fellows, not my fellowship anymore, the concept of residual risk. And we've gone to be very a complex world of secondary prevention. It is a subspecialty of cardiology. And there are the important lifestyle changes that our patients need to make. And you have a wonderful rehab program here in Ottawa that is a jewel, I'm sure, of your institution, but for Canada. But beyond that, there's important pharmacologic therapy that we as clinicians need to be aware of. And it has to do with residual risk in the cholesterol pathway, inflammatory pathway, thrombotic pathway, triglyceride pathway, Lp(a), and diabetes risk. And for every trainee in the room, you should be, as you come out of your clinical training, in addition to being able to put in an intra-aortic balloon pump, know how to prescribe a GLP-1 receptor agonist or SLG2 inhibitor and where the indication is there for that, because that's an important aspect of cardiology care. So I want to go over the role of menopausal hormone therapy and CV risk in women in a little more detail. So I'm going to take a patient. This is a patient who comes to us. And so what does it mean? First of all, what symptoms does it treat? I'm going to go over the basics. Do we ever ask this if we're internists or cardiologists? Usually not. Okay, so I'm not suggesting you're going to ask all of these questions, but you can ask if someone's going, so are there any changes in your menstrual periods? Are you having hot flashes? Any local vaginal dryness or concerns of sexuality, trouble in your bladder? These are things that family doctors often ask. This is an MQ6 questionnaire that my friend Dr. Susan Goldstein developed. It's a tool for menopause, trouble controlling your bladder, sleep, and mood. But it is okay, and her sleep was light and disrupted, and she wanted treatment. This is a woman we saw. It is okay for you as a cardiovascular specialist to certainly ask. It's okay to ask anything you want, but it's appropriate for you to ask about sex-specific risk factors. And if you've got a woman at midlife, how are you sleeping? Are you having symptoms of midlife or menopause? General question, something that we can all be asking. Okay, so we talked about the fact that older studies had suggested CV benefit, but we think about this, those older studies were confounding because the women who seek menopausal hormone therapy were better educated, had a higher socioeconomic status. A lot of nurses out there, I still have nurses wanting to stay in my practice on their therapy, have greater access to healthcare resources and treatment for CV risk factors. So those who sought menopausal hormone therapy were more likely to adhere to other wellness advice. They tended to be leaner and exercise more. And so that's where the data was confounding originally. But women who became sick with other conditions were more likely to stop menopausal hormone therapy. You know, when I was a cardiology resident, we talked about the confounding data looking at treatment for suppression of PVCs. It's the same thing. We look at menopausal hormone therapy, right? You can't use just observational data. But there was a good Cochrane review, it's almost a decade ago, looking at the meta-analysis of women in cardiovascular disease. And I'm going to show you the specific curves in a minute. The women who initiated menopausal hormone therapy within 10 years of the menopause had actually lower CV events, but they're a low-risk population. However, there was a significant increase in DVT and PE in this group. Look at that hazard ratio. So these are young women putting on menopausal hormone therapy. Death was seemed to be reduced, but all cardiovascular death, but as you know, and I know there's some of us in the room who do clinical trials, death is death. It doesn't matter how you slice and dice it. All cause death, there was no difference, so it's not recommended for prevention, and that's a consistent treatment. But I want to show you this because the absolute risk of health outcomes by age groups, and I want to show you this is combined estrogen. This is unopposed estrogen in women who've had a hysterectomy. For those of you who may remember this from medical school because you've been in training for cardiovascular expertise now for almost 15, 20 years, you will remember that we add progesterone to prevent uterine cancer. So if you have unopposed estrogen, people who've had hysterectomy, I want to show you this. These are age groups, and what you need to see, and you don't need to know the fine-tuned detail, but these are cardiovascular. This is all-cause mortality. We can look at cardiovascular disease. The point is that these lines are all bigger as we increase age. And DVT and PE is a real phenomenon. And we have patients in our practice who are on menopausal hormone therapy who should probably come off of it. And we need to be aware of that as not probably should come off as cardiovascular specialists. So we have good data that informs decision making now. So I'm happy that in the last few decades, since we've evolved, we can look at more good data. My friend and colleague Joanne Manson at Harvard published over 5 years ago now, looking at the cause-specific mortality in the Women's Health Initiative trials. And women who were postmenopausal and on hormone therapy, combination therapy for about 5.5 years, or unopposed estrogen for about 7 years, there was not an increased cardiovascular cause of death, mortality, risk of all cause or cardiovascular or cancer mortality for 18-year follow-up. So this is a safe, relatively safe treatment for women who need it for severe symptoms of the menopause without additional CV risk. And I showed you those Women's Health Initiative curves to show you that DVT and PE do increase. Okay. The other thing that our guideline talked about, I'm just going over details, that women with premature early onset menopause tend to be at increased risk for cardiovascular outcomes. There's not going to be a randomized controlled trial, but providing menopausal hormone therapy until the average age of menopause may decrease the risk of cardiovascular outcomes. So not that we would be prescribing it, but you might see someone for a serious or not serious condition, as I said, the asymptomatic SVT and the Holter that you get sent for, and it's appropriate for you to go back and tell their healthcare provider, this woman has gone through premature menopause, and she's only 43 years old. I would recommend you start menopausal hormone therapy until age 51. So with no increased baseline CV risk, women who are under 60 can initiate therapy, and because they're generally at low risk. This is if they're having symptoms. What route of menopausal hormone therapy? We have some data, but we need better data to discuss guidance. There's all sorts of new drugs out there, and we can talk about this at Q&A. We have conjugated estrogens and a selective estrogen receptor modulator, almost bazodoxifene, and there's tibolone that was prescribed here. There are all sorts of drugs that we are not in our cardiovascular realm that do not seem to be increased risk of CVD, of VTE or stroke, so non-hormonal in that way. But for older women, and these are the women we see in our clinic, these are the women who are coming to us for other reasons, and you see that on the list. It is our responsibility to send a note back and have a conversation with the primary care provider and talk to the patient in front of us, the person in front of us. So if women are over 60 or initiating menopausal hormone therapy 10 years or greater after their menopause, who are at higher than average CV risk, or who are at higher than average CV risk. So you've got someone that 57-year-old in our scenario, she was actually treated for hypertension and dyslipidemia. So her stroke risk is increased and her VTE risk is increased. And so we want to mitigate and minimize her risk. It is true that the transdermal estrogens do not have first pass analysis in the liver, so there is less likelihood of DVT and PE, but we do not have that data. It's not on a label anywhere, and so we have to weigh risk benefit for our patients. So if we look at what we have to do, we have to focus on symptoms, and that's what many of our providers that we share care with will be doing. We have to look at a clinical approach that is individualized, just as we do in cardiovascular medicine. You know, I'm sitting reading PET scans and we jail the diagonal, and what do we do about it? Well, we likely treat this person medically, but it depends on their symptoms, right? So we have to look at what the personal preferences are of that patient. This is what we are doing for cardiovascular medicine across the board and medicine, whether we're thinking about TAVR in a patient or whether we're talking about menopausal hormone therapy. How symptomatic is the patient? Well, TAVR certainly, and how bothered is a slightly different conversation. Personal preferences, what does she want? And overall health status, will it be safe? Because I think that is something we have to talk about. And you know, in the symptomatic woman who's younger and is interested in menopausal hormone therapy, if she's actually, it's probably safe, but if she's over 60 or more than 10 years after menopause, we have to consider other options. I'm not going to go into detail, but there are some interesting things that we didn't know about even several years ago. It turns out there is a mechanism now for hot flushes in the brain, and there's a CANDI receptor, and there are antagonists to this receptor. So there are now pharmacologic agents coming out that now block menopausal symptoms, and they're non-hormonal. So I think we have an opportunity to treat our patients who need it. But if we look at our Canadian recommendations, menopausal hormone therapy should be offered as the most effective treatment for the relief of menopause. Good evidence for that. When prescribing it, we use a lowest dose of estrogen, and estrogen only should be offered to minimize risk of DVT and PE. But the lowest effective dose of estrogen, and you have to look at the data. So the data isn't great. We should be prescribing transdermal when we can, and using combination. We should think about different types of progesterones. I'm not going to talk about with this audience today. And it's for relief of early menopausal symptoms. But these agents, this is 5 goes together here. The selective estrogen receptor complex we use with the progesterone to provide menopausal therapy and uterine protection. And we can relieve menopausal symptoms with newer compounds, and we even have non-hormonal compounds. But what I wanted to point out here more than anything is that the evidence supports the aggressive identification and modification of risk factors as the most effective means of reducing cardiovascular risk. So this is an opportunity, and if you're talking to colleagues or you're teaching family doctors, I use midlife as an opportunity. If someone's symptomatic, there's a whole host of decisions we need to make as healthcare providers, and CV specialists play a role in many of these women. But for women who are not having symptoms, menopause or midlife is an opportunity. And it's not indicated for primary or secondary prevention. And we do know that I've talked about women who go through premature menopause appear to be at increased risk. So we should think about replacing them. Lack of high quality data to look at the roots of estrogen. But these are the key messages before we talk about, I want to leave some time. I always want to leave time for Q&A and talk about some other things as well. So we use it for relief of symptoms, but it's not indicated for the primary or secondary prevention of cardiovascular disease. We should not be using menopausal hormone therapy in women who are 10 or more years after midlife or menopause or at increased risk for cardiovascular events. So those are most of the patients you're seeing in your practice and coming through the Heart Institute. We need to look at the list of medications that says, I said, have a conversation with that woman and send a note back to their primary care provider about trying to come off of the hormone therapy. And then it's a risk-benefit conversation, as most of our interventions are in medicine. We do need more data to provide guidance on the impact of estrogen administration for routes of thromboembolism and CV risk, although we tend to feel that even though there is lack of data yet, transdermal estrogens are probably at lower risk. And I say probably because we've been fooled before, right? We need to do the right trials. And women who initiate menopausal hormone therapy shortly after menopause are at low CV risk. These are usually not the women, although they can come into our practice and be seen at the Heart Institute, but it's the subsequent years that we want to reduce their risk. So I've talked about some recommendations and changes in practice. I want to spend some time just talking with the group about other things as well. And if I can give you 2 pearls, as I end the talk about menopausal hormone therapy, it is number 1, if I challenge you to ask everyone that's coming through your clinic about sex-specific risk factors, hypertension or diabetes during pregnancy, even if you have a 60-year-old woman in front of you, because that actually increases her risk. Okay, this is assuming this patient is not in the secondary prevention realm right now. Okay, because that woman requires treatment regardless. And then the next thing is age of midlife, or premature menopause or not. And I'm very fortunate that time has evolved, and we actually have a chapter, we have a textbook on sex differences in cardiovascular disease. I was fortunate enough to write a chapter on peripheral arterial disease with my previous fellow, Kajeni Srivatharajah. And we've come a long way, but we have a lot to learn. And we're all here today because we care about patients and we care about making a difference. And I'm going to end with a little anecdote of what happens in life when you get in a cab and you talk to a cab driver. I took a cab or an Uber over here, and where are you going? Yes, okay. Oh, and I started chatting. He moved to Ottawa because the son is in school, grad school. Oh, he's in law school. Very nice. Okay. And I guess, and my other son wants to be a cardiologist. His other son is a cardiology fellow in Toronto. Came from Ethiopia, worked hard, made a difference. This gentleman is a mechanical engineer driving an Uber to make sure that his kids can make a difference. And you know what? We're all here. We all have a different story, but we all have a story, and we're all here to help our patients. So if I can thank you for inviting me back to Ottawa to give a talk. I am going to have some time for Q&A. I did not spend a lot of time going through the basic science of candy neuron receptors. I didn't think this was the right group to do this. And I didn't go into a lot of preventive cardiology, but I'm happy to talk to people on Teams or in the audience about preventive cardiology and women's health. With that, I thank you.
Thank you so much.
Sure.
So one of them is for our patients with SCAD who are perimenopausal. For whom hormonal therapy can be a risk factor for triggering SCAD.
Yes.
What are the non-hormonal therapies you are recommending? And thus far, transdermal and topical preparations and SMRIs have been acceptable. Or is there anything else?
Yeah, so that's a really good question. It's an opportunity for us to sort this out and collaborate. Let me take a pause back. You have a SCAD clinic here. We have a SCAD clinic at St. Michael's. We're opening a women's health program as well. And I think we need to look at the data and do this systematically and collaborate because we don't have the data. The new candy neuron receptor antagonists that are coming out, they're approved and they're coming out in Canada. Excluded people, it said women with cardiovascular disease, but I was on one of their advisory panels and looked at this, and the cardiovascular disease was a question of an arrhythmia or a long QT. So there is no way that most of our women who would need this would have been even included or excluded from this trial. So I think we have an opportunity to try and look at these women. There is no physiologic reason that I can think of, biologic reason why these new candy neuron receptor or non-hormonal treatments for severe symptoms of flushing of the menopause and sweats actually should affect SCAD. But you're right, we have to be very cautious and we have to look at alternative therapies and we have to look at risk benefit. But most of our women, I'm not sure I'm as comfortable with transdermal. We just don't have good data. Estrogen depends on how symptomatic that woman really was. The SSRI seems like a better choice, but you've got a person in front of you, risk benefit. And so we have to individualize. The devil is always in the details, but we have an opportunity to think about treating these patients. And the reason I say we have to collaborate and get together is that these women have sort of been excluded for the wrong reason. And we now have an opportunity, and there will be strength in numbers. If we can get a few people together, we'll get Ottawa and Toronto and 2 clinics together. And then you have to think of who's going through symptoms of the menopause and SCAD. It's a smaller population, but certainly it's an important population that needs to be addressed. Yes.
A fantastic session and welcome to Ottawa FACC. And so I comment on the question, so I do think the candy receptors could be actually very relevant, for many of these conditions, particularly I think some of these conditions do have, neuro and cardiac, linkages, right? So evaluation in that type of setting is particularly relevant and very, very important because of these considerations. My question is actually a more practical one, that is the duration, of hormonal therapy, for those who are requiring it for symptomatic treatment. And because I do have some patients who are in their 60s who's been put on hormonal therapy, they really actually like, that's the thing. And so what is kind of the general guideline, for how long patients should be on it, from symptomatic management point of view, and how does one actually conduct that conversation, in terms of waiting off that medication?
Comment and then the answer. The comment is 10 seconds with Peter Lou is like 10 hours with someone else. You got me thinking about candy receptors and physiology. So thank you. So the general rule is so that those women are in their 60s and they should be coming off of it. So the conversation is you tell them, and their doctors don't always know, and the gynecologists don't know or don't want to know what the guidelines are, because there is still that feeling out there that estrogens are a panacea, that they treat people. And the women who are seeing Dr. Lou, myself, feel better because their skin feels better. They're, and they just feel better on the estrogen. So let's back up a bit and say, we talk to them at the guidelines. So after age 60, we should be getting women to come off of it, or 10 years after their last menstrual period, depending on their overall risk. But what we tell women, and this is the thing, is the shortest duration at the lowest dose of estrogen. And so on average, I would say 3, 4, 5 years on menopausal hormone therapy and then re-challenge coming off. The data would suggest, and there's a SWAN study, there's several studies that look at menopausal symptoms after midlife, and 85% of women will have less symptoms the further they are away from menopause. But there is that 15% of women who have severe symptoms. And then you have, when we have conversations in cardiovascular medicine, risk benefit, there is that risk benefit conversation, but it's not for good skin. It's for severe vasomotor symptoms. And then the other aspect, which I didn't talk about, I had a question I thought I had at the beginning, I put into the talk, got saved into another version, that said, the question is, we don't learn about this in medical school, but is local estrogens in cardiovascular training, is local estrogen safe? And it is. It doesn't get absorbed. So for local symptoms, women can stay on their Premarin cream. And you have those women, you need to have a conversation. You say, no, it feels nice on your skin, but you have a risk of stroke and blood clotting to the lungs and to the legs and lungs, and even death with this. So I think that these are women that should be coming off of it. So it's about so to recap, 3 to 5 years, 10 years for sure. Try and wean off. There are some who have severe vasomotor symptoms and they say they can't live without it. There are some women, I've had several women in my practice, because I have women on my card in prevention, they get sent to me, who feel that their quality of life is just not, their mood is off. And those women, I'd say we challenge with anti-anxiety. I get the family doctor too, anti-anxiety, low dose antidepressants, not because they're depressed, but because they've had changes and hormonal changes and cognitive changes potentially, but the estrogen just puts them at increased long-term risk. Is that help? Okay. Oh, those are really good questions. Those are the same questions I heard other individuals ask at the North American Menopause Society. So you're a good question. The answer is I wouldn't be looking for risk. I would do a history and a physical and calculate a Framingham risk score. And most women who are low risk on Framingham, and age drives risk. So a 50 some odd year old woman is usually going to be low risk on Framingham, but if she's got treated hypertension, significant dyslipidemia treated, that risk is higher. But I wouldn't go looking for additional risk factors for her.
You give them aspirin for primary prevention.
No, so really good question. I would think not. Think about the mechanism of disease, and let's just talk about aspirin for a minute in general. So as you know, there have been several studies that have come out that show aspirin is not of benefit in primary prevention in the last few years. We have patients who are coming into our practice for all sorts of reasons, and they're on aspirin, and we have to ask why they're on it. They should be off their aspirin and on their statin, right? When you think about it. So the addition of aspirin is probably not enough to reduce their risk, and will increase GI bleeding in their older patients. Anecdotally, I have this patient in my head who I was always worried about. This patient is actually, I just took care of 15, 20 years ago. She was an older matriarch of the family, and the family would come in hovering, right? And she'd come in and she couldn't even, they'd be walking her in with a wheelchair. And she was 78 years old, very overweight and sedentary and didn't move, and she would not come off her estrogen. I almost gave her warfarin. I was so worried. It was before DOAX. She's a DVT and a PE waiting to happen, but I didn't. But I don't think the benefit of aspirin will outweigh the risk.
And is Framingham still?
Well, that's a really good question. Use whatever you are comfortable with and will use regularly. There are multiple risk scores. I will say this talk was more focused on women, but from a preventive perspective, we miss the mark when we talk about 10-year risk. It's risk benefit, it's lifetime risk. And when we're talking about other risk modulators and modifiers and enhancers of our patients, we're learning more and more about LP little a. If you go to LP little a guidance, there's a Framingham risk, but there's a lifetime calculator. And I think when we're dealing with people at midlife or people who are not that old or even younger people, if we think about it, it's lifetime risk. And so that gets back to your question of Framingham. Framingham is a good starting point. Framingham underestimates risk in midlife women. Okay, so some people add in like a Reynolds risk score, looks at CRP, but then doesn't take family history. I do look for risk enhancers for people I think might be at risk, not talking about menopausal hormone therapy, but putting on a preventive cardiology hat. So we will see many patients, and I started up a cardiometabolic clinic. They're actually the children of the people you've saved lives or not at the Heart Institute. So people are left with trauma seeing their parents have a cardiac arrest at 47 or 57. And then they come out and they're older and they see those risks, they get a risk calculation. And you see actually we're checking LP little a's. I'm doing a carotid IMT with edge detection software. We're doing all sorts of things to look at risk. But then I have a conversation with that patient because then I talk about lifetime risk benefit. And the benefit may be psychological reassurance knowing that they're on a statin because they've had some CV trauma. So back to Framingham. So Reynolds risk score does not take into account family history, but I think in women at risk, I look at sex-specific risk factors. I will add, as in everyone, an LP little a. I might do CIMT. It depends on the family history. And then we have a conversation risk-benefit of lifetime risk. So that's where we individualize. But for most people, Framingham is a good starting point. Having said that, we're in the era of PCSK9 modulators, inhibitors, like a vaccine against cardiovascular disease. Not that we're going to give everyone inclisiran at the age of 12, but I have patients in my practice who are on inclisiran because and in primary prevention, not secondary and are paying for it because they've seen someone in their life and they want a lifetime risk reduction. So I think we have to think and change our paradigm a little about risk assessment and risk reduction. There is a population strategy and it's a sounding board, and I use Framingham as a starting point, but use what works for you. If you want to use Euroscore or whatever you want to use.
That's great. Thank you so much. If you have any questions, please good week, and please come to us next week. We're talking about athletes. Have a good week.